Kelly, it's about 10 of here. Can I go ahead and just start introducing myself then?
That would be wonderful.
So perfect. Thank you, everyone who's with us live and watching this later. I'm Dr. Danielle Plummer. I'm a pharmacist in Las Vegas. I wear many hats. One of the things I do is help women with extreme nausea and vomiting during pregnancy. And it all ties in with maternal mental health. So I stepped into doing pharmacogenetics. I'm certified in it through a company that Carrie will tell you about. And it's just a game changer when it comes to prescribing by decreasing adverse effects and finding which medications have the most benefits. So I could go on talking about everything I do, but that's not the intent of this presentation today. So Carrie, oh, and I'm she, her. I'm still getting used to doing pronouns. Carrie, I'm going to turn it over to you.
Thank you very much, Danielle, and a wonderful day to all of you. I hope your weather is as beautiful as it is here in Austin today, a perfect 70-degree day. I am Dr. Carrie Lalonde. I am the Vice President of Clinical Operations for RX Genomics, and we are a pharmacogenomics service company. Just a brief, what is a pharmacogenomics service company? We are not a lab. We specialize in actually providing the recommendations, summaries, as well as interpreting the reports to get to that point for different providers, different patients, and that is basically the role. I mentor and train pharmacists as well as work with patients directly, and so I was very excited when I met Danielle, who is also a Crichton alum. So this is super exciting stuff that we are both from Crichton, and her work in the hyperemesis field and helping women who are pregnant to let them feel better and really enjoy their pregnancy is just super important work.
Yeah, it's one of those things when you've taken away somebody's ability to eat, to drink, and to exercise. Like those are the foundations of healthcare, right? Of health. We take that away. What can we do? And that's where we have to turn to medicine. And I've never met a pregnant woman that said, give me meds, I want meds. No, they're very scared. It's a terrifying experience and they've lost all their strength and nutrition. So what can we do? And this is just one of the perfect opportunities for pharmacogenetics, genomics. I'll get into the difference in a second. I did meet a doctor recently who works in the oncology space. I worked with a few of them, and then one who works in maternal as a specialist in maternal care and said, yes, we're just decades behind oncology. So here we are. Thank you so much for having us. And we're excited to tell you about this and hoping soon it becomes a standard of care in prescribing because it just has to be. Okay, let's see here. So one of the things I loved this little background I found. It's DNA, of course, but it's dice. So stop rolling the dice with patient outcomes. We can use personalized medicine. And here are some topics I'm going to go over during the next hour. The goal to speed up recovery and reduce suffering. So what is pharmacogenetics? The very, very short explanation from a bird's eye view using DNA to guide drug therapy. And Carrie, you're, I think, more of an expert on the definitions and the science behind it than I am. So I'm going to let you get into it on the next slide. But I did want to differentiate first. You'll hear the terms sometimes used interchangeably. Pharmacogenomics is looking at the entire genome, where pharmacogenetics is looking at the gene that a medication is used to break down and get to its site of action in the body. Carrie, did you want to add anything to that before I move on?
No, that's absolutely perfect.
Cool. Okay, so there's what we call 4 types of metabolizers. So what we're looking at is when somebody takes a medication, from the time we get it into our body, the process it goes through the body, and there's sciences behind this, pharmacokinetics, pharmacodynamics. We're looking at how does the body respond to that medication. There's enzymes in our body, enzymes are proteins, and they're going to be different variations depending on our DNA. And I like to think of it as like the spectrum. On one end, you're a poor metabolizer, and the other end is the ultra rapid metabolizer. And we have the two in between. So that's my bird's eye view. Carrie, do you want to talk about any of the differences and how our body's going to react depending on which one of these metabolizers we are?
Sure. And generally speaking, I mean, you may also see a 5th type of metabolizer in here. It's not very common, but it's a rapid metabolizer. So it falls between your normal and your ultra rapid. Typically when that occurs, you have an allele or a change. That means that it's slower on one side and maybe and ultra rapid on the other side. So if you've got like a CYP2D6 duplication, so you've got lots of copies of the gene, and then you've got a poor, another side of it that's really slow, you may actually fall into that rapid category, which I apologize in advance if I talk too clinical. So if you have questions about all of this, please feel free to ask, but you are correct. And, there are definitely 4 metabolism statuses. A poor metabolizer, when we talk about the way that medications work in the body and the way that the body works with medications, if you're a poor metabolizer, you have an enzyme that is looking for the drug to metabolize it to either the inactive or the active form, one of two things is going to happen. Either A, you're not going to get any effect from the medication. So if you're looking at tramadol, you're not going to get the analgesic effect. Or B, on the other end of it, if you're an ultra rapid metabolizer, you're going to blow it out of your system too fast for an active drug, and you're not going to get any effect from that end too. And obviously, all the other steps in between are variations of exactly those two explanations.
That's how I like to explain it. It's interesting you talked about that 5th type. Originally, when the science, it's been around, 20 something years now, pharmacogenetics just recently became, I'm going to say within the past 5 years, maybe, give or take, really accessible for easy for everyone to have done. But different organizations and scientific communities around the world were defining it differently. And now there's all the organizations got together and said, hey, we need we need to be consistent with how we're talking about this. I think there's still a lot of variations, and you still, just like you said, Carrie, might see that 5th option between extensive and ultra rapid out there. So exactly, it's just all about, our bodies are so unique and different. And this is one of the ways that we can use those differences to guide drug therapy. So as I mentioned, it's actually a really easy test. It's a cheek swab. It's not a blood draw. It's not anything invasive like a lot of pregnant women will deal with. So here you just go, you could do it at home now. Before COVID, you get it done in your doctor's office. We can mail you the kit. Very simple instructions. It's painless, like I said, not invasive. You do 30 seconds on each side. You just sit and let it dry for a few minutes, mail it to the lab, and then the results are sent to the doctor, or in my case, consulting pharmacist, which I then share with the doctor to make the best medication and prescribing decisions for the patient. Carrie, anything you want to add about how it works? Wait, I can't hear you suddenly. Is that my sound or yours? Okay, Carrie's reconnecting to her audio here, so bear with us with our technical difficulties while she does that. Let's see, while we wait for her to reconnect, let's see. Kelly, can you hear Carrie? Oh, there you are. Okay, perfect. I can go back maybe.
Okay, let me take my headphones off since we're having fun technical difficulties. Is that what I call a Monday, Thursday?
Yes. Sorry, I jumped onto the next slide and my back arrow is not, those are my technical difficulties, not going backwards. So that's okay.
So the only thing I was saying about your previous slide was that consultant pharmacists are extremely important when it comes to pharmacogenomics. Okay, you can get results from any number of genetic testing sites out there, but interpreting that report, understanding the full breadth of what that report is saying is key to it. Understanding, again, the pharmacodynamics, the pharmacokinetics of a medication, and then putting that into perspective with not just your genes, but also with your lifestyle, your drug-drug interactions. If there's a drug-gene-drug interaction that needs to be addressed. These are all different aspects of actually what we consider medication therapy management in combination with pharmacogenomics that we put into play to get to that next level.
Absolutely. And even food, right? We know pregnant women don't take statins, but it's always the perfect example. You don't want to have grapefruits or grapefruit juice because that's going to alter the metabolism of the medication as well. And as you'll see as we go through the presentation, there's ones that we might be taking through our maternal time that would have that same effect. So I'm just grateful to be in a role where I can help everyone that needs it. I put the slide up here, not to anyone to like dive deep into this, but just so you can get an idea what it is that we see and why you'd want that consulting pharmacist to be involved in this. Because we go through, in addition to being a doctor of pharmacy, we go through additional training to just exactly to understand this in pharmacogenetics. So I didn't mention, but a lot of times people think of pregnancy and genetics. They're looking at the genes that might bring on other disease states. We're looking on the genes that are related to medications and how they work in your body. So this is a sample of what we see here: the gene, the genotype, the phenotype. And depending on the lab, it may or may not have one of these reports. A lot of times it's on us to take the information and then figure out what's going to happen to that medication and how that pregnant mom will then respond, or non-pregnant mom, we use it in all ages, respond to that medication. So this is something that they do get carried. This came from RX Genomics, of course, and I just love this. It is a sample patient information card. Again, the patient is not going to look at this and know what to do, neither would the doctor. But these genes don't change through the patient's life. So if they ever are on another medication later that is followed by one of these genes, then we can say, okay, let's take a look and see, is this a good medication for them and how will they respond? Why use it? I was tempted to put this first, but because this is so important to me, but I just thought it'd make more sense if you knew what we were talking about first before I got into the why. So why use pharmacogenetics? You're really looking to find the safest, most effective medication for each individual. And our goal here is to have your benefits outweigh risk. There is no such thing as anything safe that we put in our body, whether it's a food, a supplement, a medication. There's always going to be some type of risk or potential adverse effects. And this is how we can use it, by looking at our DNA to find that what's safest and most effective with the least risk. This study, I just thought I had to include this in here. You can see the link at the bottom. It said recent, but this was, the numbers are so much higher now, I believe. This said a study of over 340,000 women who had a live birth between 2006 and 2011. About 10% used a psychotropic drug during pregnancy, varied from 6 to 15. And I would highly, I'd be confident saying the numbers are even higher now. So we have this, a lot of women that are taking medications for mental health while they're pregnant. But how are they currently, how are we determining what medications they're going to get? First, we have to look at who's prescribing the medications. And this will depend at what point in the pregnancy, where they live, what insurance they have. There's many factors that come into play. Ideally, it's a psychiatrist. It could be an obstetrician or any type of specialty within maternal health, primary care doctor, and emergency room practitioners. And I like to use the word practitioner because it might not be an MD. It might not be someone board certified. It could be a nurse practitioner, an APRN, a DO, PA. There's so many acronyms. And if you're on a military base, it opens up a whole nother can of worms on who might be prescribing your medications. We want to look at who's paying. Are they self-pay, or is it insurance coverage? And if it is insurance coverage, what plan do you have? Because it varies, again, where you live and what plan you have. And a lot of times it's insurance dictating prescribing and not the doctor or practitioner or the patients, what they're advocating for themselves. And then the big factor that's so important and often gets overlooked is who's monitoring that patient. How often are they getting checked? I just see all too often a patient gets started on a medication and nobody follows up to say, is it working, or are the adverse effects outweighing the benefits from it? And then at what point are we stopping that medication? My example, because of the population I work with, the pregnant women with hyperemesis gravidarum, the guidelines say start with what we know is safest. And I'm going to do my air quotes, safest. Safest in pregnancy, we were talking earlier, means it's not a teratogen. It's not going to affect necessarily the safety of the baby, but there's still adverse effects. So when we look at a medication like diclegis or Bongesta, which is a combination of vitamin B6 and an old antihistamine, called doxylamine, it goes by the brand name Unisom on its own, combined, put into a long-acting formulation, it's still going to make you sleepy. It's still going to have what we call anticholinergic effects. If you're already dehydrated, these effects are going to then multiply. But because it's considered the safest and one of the first in the guidelines, then all these patients get started on it, but nobody ever says, hey, I don't think it's working. Let's taper you off that and see what would be safer. So that's again where Carrie was saying, consulting pharmacists, we're the ones who are going to monitor to you through your pregnancy and then continue to tailor that medication based on how your body's responding to what's been prescribed. It's been brought to my attention, the Swiss cheese model in healthcare. There's just too many holes right now. So pharmacogenetics really helps fill one of those holes, fill the gaps for safer prescribing. Current medications are not working because women do not see, on a whole, there are exceptions. These are generalizations. You don't see your OB till 10 weeks. I work in a hospital here. We have women every time I work in the emergency room for dehydration and malnutrition, and they may or may not be actually labeled as hyperemesis gravidarum at that point, but some nausea and vomiting early pregnancy is good. Does that mean it's safe? And then they get discharged. Do they have medications? It takes months to get in to see an obstetrician at your first pregnancy. It's the ones later on, like, okay, let me get set up first before I get pregnant, or if you're going through IVF, you might have something lined up, but the majority don't. So you're 2.5 months of just being seen between emergency room doctors, maybe a primary care doctor. A big hole in healthcare here. Carrie, you and Kelly and I were just talking. You can't have a clinical study with pregnant women, not a placebo-controlled, double-blind. It's just not going to be safe because nobody's going to step up and say, "Yeah, I'll give that med a try." So all the studies involving pregnant women are really retrospective. There's some prospective, but they're going to be open label, of course, when a pregnant woman's already taking a medication and then becomes pregnant. Most common may not be the safest and most effective, like I was saying with diclegis and Bonjesta. Right now, it's all trial and error prescribing for mental health medications. Very high risk of adverse effects. And as far as I know, I have not met an OB or midwife who is board certified in psychiatry. If anybody can find one, please share. But as far as I've seen, OBs and midwives do not have extensive training in psychiatric medicine. And a lot of the psychiatrists that my patients are seeing will say, do what your obstetrician prescribes. And they're stuck in that hole in healthcare and they get bounced between. So this is where that consulting pharmacist can come in, because there is a better way to prescribe. And here, I'll let you speak in a second. I just wanted to throw this one out here because this is something where the patient population I work with are these pregnant women with extreme nausea and vomiting. And the mental health component that correlates with this is so profound, and it's ignored by, I feel, most of society. They say you're pregnant, it's normal, you'll be fine, it'll go away at 12 weeks. But when you look at the women asking for help, it's not normal, it's not okay. It's when it goes too far. Again, a little nausea and vomiting, it's good, it's a protective mechanism. But when you're losing your hair, your thyroid, you want to terminate, you've lost your job, your heart is stopping, when you've miscarried, when your marriage is ending, how do we handle these women? And I just put one nice little success story where a woman said, my life changed. She got gabapentin steroids. Again, we don't want to do that till you're about 10 weeks on the steroids, so heart and palate are formed. But that's where we want to use pharmacogenetics and say, this is all preventable. These women should not have suffered in this way. And this is just a tiny sample of all the women that reach out to me. And mental health just comes into such a big play. So Carrie, I'm going to turn it over to you for a little bit, because this is your area of expertise. What do we have going on here? How can we use it for maternal mental health?
So one of the things we have to remember when we start talking about medications in general, and we start talking about pharmacogenomics in the context of mental health, is that when you have a pharmacogenomic test completed, your DNA is not going to change. Okay. What may change your DNA or change that, turning the genes on and off, is something we also call epigenetics. Okay. And again, that's the consultant pharmacist that can work with you during the process of pregnancy and how that may or may not be turning some genes on and off. But in general, when we look at our mental health medications and we look at our pharmacogenetics, we look at the way, not only the way they're metabolized, but also the way they move around the body. It's one thing to metabolize a drug to its active or inactive form, but what's more important is it getting across to where it needs to go? Does it go across the blood-brain barrier? Is it utilizing a transporter? What transporter is it using? What gene creates that transporter? And then following, especially with behavioral health, is it getting into the right, is it getting to the right receptor? Does it go down that right neurochemical pathway to get to that target receptor? Is the serotonin going across the correct post-neuron, okay, postsynaptic neuron to get to that next level to create the effect necessary? Or is that drug actually blocking the reuptake of that chemical neurotransmitter? So we take all of that into account, but most importantly is, like we've already alluded to, Danielle's already said it numerous times, safety. Okay, we know what the safety level of many medications is. Okay, a lot of times people prescribe Celexa right off the bat. Hey, it takes some citalopram. Well, citalopram, thankfully, is one of the most studied behavioral health or antidepressants on the market today. But when we look at citalopram, we look at CYP2C19, we look at GRIC4, we look at the HTR family of genes. Okay, and these are just some of the, these are some of the transporters. And so if somebody comes to you and they say, oh, well, you know what, your metabolism status is this. Okay, well, that's an important piece, a very important piece to know, because if I'm a poor intermediate metabolizer of Celexa, I'm going to have a lot more of it in my system for a lot longer. But if I'm a rapid or ultra rapid metabolizer, it's going to get out of my system really fast. But is it even going to get to that target receptor? Is that drug going to block that SLC6A4 gene from producing the protein, that causes it to go back up to where it needs to go to get stored? Is there going to be enough of that in there? The other thing to consider and to keep in mind, when you start taking an antidepressant, typically, because of the way our bodies work, it will take up to 6 weeks for that medication to get to its therapeutic effect. Now, granted, okay, and one of the reasons why they all have black box warnings that say that, look out for suicidal, tendencies and so on and so forth in the first 2 weeks, is because it typically will give an individual just a jump start on that happiness. It'll be like, oh, hey, you know what? I'm in a great mood today, but it also clarifies your thinking. And so that was part of some of the reasons why this occurs. So keep that in mind as we're talking through not just the pharmacogenetics of things, but also, how does it move? How's metabolism, transporters and so on and so forth. So what Jamie's put up, Jamie, I apologize, Danielle. I get another pharmacist on my brain too. Sample medication interpretation. So this is what they call dosing guidance. Okay, this is part of the report. It's not an end all be all. However, it will give you a good idea of where not to go. Okay. That is not to say that if you have been taking a medication that is safe to take during pregnancy and all of a sudden it's got a big giant X next to it and you're happy with it and you're comfortable with where you're at, that doesn't mean stop taking it. That just means let's go ahead and monitor, because your body is going to be changing. Pregnancy changes our bodies. Pregnancy is rough on our bodies. But it's just something that we want to monitor, but it doesn't mean go ahead and stop. You might be taking other things that are actually helping this medication to be effective. So just keep that in mind. Okay, Jamie, I did it again, Danielle. I'm so sorry.
I want to know who Jamie is. It's okay. Can I tell you, curious twins. So the fact if you're short on sleep, I think everyone here, we're moms. We do this and we do a lot. And I'm thinking everyone who's with us today is as well. And we all understand. So I thought this was interesting that you mentioned citalopram. This was actually one of the women I work with, and didn't know you were going to mention citalopram today. And here you can see that she's at risk for it not working as well based on this HTR2A variation. And that's one of the ones I've studied the CYP, the cytochrome P450s really well, but this is one I don't have extensive studying in. So it's very interesting.
This is that HTR2A gene actually produces the transport protein, or is part of the family of transport proteins that are located on the postsynaptic neuron. So if I had a visual, there's a presynaptic neuron and a postsynaptic neuron. The presynaptic neuron is where the serotonin, dopamine, norepinephrine are all stored. And the postsynaptic neuron is kind of where we push all of those serotonin and all those neurochemical transmitters across to. And so in order to get it across, you got to have those transporters. And that's where if you are missing some of those proteins and some of those transporters, you may not get that therapeutic effect you're looking for despite the proper metabolism.
And it's interesting when you talk about citalopram and this specific transporter trying to get to one of the hormones being serotonin, that up to 30%, different studies will say different things, of women are using ondansetron, brand name Zofran, for nausea and vomiting. We say nausea, but it really doesn't work. It's really an antiemetic. And they're worried about serotonin syndrome. But in a case like this, it actually might help the citalopram work better if they're on both. So other side effects might come into play, like constipation or headache, but this one I threw in there just because, again, the patient population, the women I'm working with, all of these medications we can help guide together. These are all ones that might be prescribed to a pregnant woman suffering from nausea and vomiting. And these are all ones where they're not directly mental health medications. You can look and see that there are just carried, just like you were saying, that they're going to interact with the other medications that you might be taking for mental health. And a lot of these antiemetics, like compazine, was actually an antipsychotic with its own set of adverse effects. And there's other ones that are prescribed. A lot of times when these pregnant women go into the emergency room, they're going to be prescribed other medications as an antiemetic to stop their vomiting. And they actually are antipsychotics. We have Haldol. I've seen there's a bunch. Anyway, so these are all different medications where pharmacogenetics can step into play that we see with our pregnant women. And I like the slide too. Again, you don't need to analyze it right now, but these are the genes that correlate to the medications I just showed you. And that's where someone like me or Carrie or a consulting pharmacist can look at this information and help make that prescribing information and then adjust the dose accordingly. And Carrie, just like you said, if you start an SSRI and it's going to take up to 6 weeks to get to the effect that you need to feel better from it, 6 weeks in a pregnancy is a very long time. Let's see, should we start with a higher dose? Should we start with a lower dose? Should we try a different SSRI? And that's where this information just comes in beautifully. And it's not just mental health. This was another one I found from US Pharmacist magazine. And no, we don't take most of these while we're pregnant, but I wanted just to show that there are other medications we can be taking that will affect our mental health as well. I've met a lot of women who are on ADD meds when they become pregnant. And then, just like you said, all of our hormones start to change. So much changes in our body. And we want to know, how is that going to affect? And if we start another medication, how will that affect us? And we can look at the genetics behind it. And this was an example here of ondansetron I mentioned. I personally found out as an ABCB1 gene, this is one of these transporters you're talking about, I don't respond from it. And I've met so many other women that go, they prescribed me Zofran, this ondansetron, and I'm telling them it's not working. They don't believe me. And I am just urging every healthcare practitioner, when a woman goes into you and says, it's not working, please, please, please believe them. And when they were able to see this in black and white, it was this feeling of almost like redemption, going, I knew it didn't work for me. And this is one of the reasons why. So here, this interpretation was, monitor for decreased response. I feel like I jumped through a lot as far as medications. I just wanted to go back to the first slide from that section that said types of medications. I didn't mention any names. Carrie, you mentioned Celexa. The opportunity is just huge with your antidepressants, anti-anxiety, antipsychotics. These are all ADD medications. There's so many. We have ones for OCD. There's just so many medications. So I didn't want to put a list of all the meds, but as long as we know how it's metabolized, which genetic pathway it's following, then we can help use it to guide our medication therapy. Okay, 2 ways to pay for this test. This is one that Joy here with 2020 Mom said, how do we get women to get this covered? Carrie, I ended up going through RX Genomics. Of course, I partner with your company because as a pharmacist in the state of Nevada, I cannot yet bill insurances for consultations or order lab tests. There are other states that have protocols in place that allow pharmacists to do this, but this is the perfect arrangement for me. In this case, it's $429 through me or through RX Genomics as a self-pay. There are other labs, other companies. I've seen it go up to 2,000. I think this is the lowest I've seen. And you can use your flex spending cards as well. Did you want to add anything to that?
Just the only thing I'll add to that is that it's the 429 is not just for the test. Okay, that also includes the consultation, which is actually takes quite a long time, especially when we're talking about women who are pregnant, because you take an individual from who may not necessarily be initially a complex patient, but you add in pregnancy and it becomes complex. And so the amount of time a consultant pharmacist will typically spend can range anywhere from 2 to 4 to 6 hours, depending upon what we're trying to accomplish, what the patient's desires are, and communicating with that practitioner in order to get them to the outcome that they are expecting.
Absolutely. And just like you said, I don't just do this on my own. I partner with those practitioners to make sure we're doing what's safest and most effective for the patient. Getting a call back from a doctor's office is not the easiest thing. It doesn't matter what type of doctor, right? It's just a challenge getting those meetings. A lot of times, it's really on the patient to say this is to be an advocate and to be there and say, hey, my pharmacist is trying to get hold of you. How can we meet? And all that comes into play with this test. Yeah, I agree. And it includes the lab fees, the mailing, the consultations. It's a very involved process. And for most of us, it's not a one-time, one and done situation. Again, I follow women through their pregnancy, and we're going to make those adjustments as needed. And just like you said, if it's going to take 6 weeks, that's if you're starting a new medication. A lot of women are on mental health medications when they become pregnant. And I have some case studies coming up at the end, but all of a sudden, the obstetrician will be like, oh, stop that. We're going to start you on this. But you don't want to just cold turkey stop a medication because you have that 6 week for the new one to build up. So you have to work with a pharmacist on how to taper one off the other. Or let's look at the research. Let's talk to the manufacturer. Let's see what's going on. Do we have evidence that it's safe in pregnancy? Just like you said, if a woman is stabilized on a mental health medication, becomes pregnant, it's working for them. Ask the question, do we really need to change them to a different one? And that's, again, pharmacogenetics can step in and say, okay, doctor says we want to change because we don't know about that med. What can we do and what's the best? And all this comes into that, this fee. It's not just a lab fee, like you said. As far as insurance, okay, Carrie, you and I had a conversation about this, and it seems to change regularly. As far as I know, Medicaid in about half the states is covering it. Nevada does not. And then you enlightened me recently, Texas did, and then they didn't. And what's going on there with Texas Medicaid?
So at last check, Texas Medicaid was not covering pharmacogenomic testing. And that changes in the best opportunity to have a pharmacogenomic test covered by your plan is through a prior authorization. Okay. Medicare Part B will cover it, but typically women who are becoming pregnant do not have Medicare at this juncture. So United Healthcare Commercial, their commercial plan will pay for pharmacogenomic testing in the space of behavioral health, because they have found that there is a cost savings to the insurance plan of about $5,000 per year versus the trial and error process. So of course the insurance company is like, wow, $5,000 a year, this is awesome. They're going to go ahead and pay the $429 or whatever it is that they're being charged for by the lab, that fee. That being said, there's also, with a prior authorization, and you can prove, or your doctor can prove, medical necessity, then you also have the option to then go the route. And now I will say prior authorizations have a tendency to take a very, very long time. Doctors' offices typically do not like doing them. But hopefully yours is one that advocates for their patient and will actively pursue this on your behalf, so that you, as a mom, as a patient, as a pregnant woman, you don't have to suffer through the consequences of the trial and error process.
Absolutely. And I'm glad you mentioned that prior authorization. A lot of women have reached out to me and said, hey, I want to have it done. I have insurance. Will it be covered? And when I look into their specific plans, there's a lot of nuances that go behind it. That prior authorization proving medical necessity is one, but seems like a lot of times, just like you said, they'll cover it for mental health. But they won't cover it yet for maternal health, which again, all these medications, I showed the slide earlier that we're taking for different reasons in our maternal time frame fall directly related to mental health. So, somehow we got to get these insurance companies to start covering it. I've seen some that'll cover very specific medications, but not do a full panel. And then there's other options, I think, where you can go through like third parties that have smaller panels and may cost less, but you're not going to get if you're getting it done, if you can just get the whole thing, like I showed earlier, we know those genes, and we can then look at it's not going to change through your life. So if you're ever in the hospital, you need pain medications, you unfortunately maybe are diagnosed with a type of cancer. We have the answers right then and there already, and you don't have to keep trying to fight with insurances later on to get it. So if in this situation, me personally, then I'm going to work with your doctor. They can bill the insurance. Their office is going to do the paperwork, and then I'll just charge a consulting fee for my interpretations and to work with that mom and partner with the doctor through the pregnancy. So I feel like I skipped some slides earlier. I don't know how I would have done that, but we talked about the number of genes and the number of meds. Carrie, did you see that? I feel like I skipped that one. I don't know why. No?
No,
Yes, no?
no, I didn't see that one.
Okay, I don't know why oh, there we go. Now my back arrow is working. Why?
I will say this
Is
about
it,
the insurance and everything in
where did it
labs.
go?
Just be aware that all the genetic tests out there typically have a different panel, and not all the panels are going to cover things the same way. So, CYP2D6 is a very, very important gene that produces the namesake enzyme CYP2D6 for metabolism, but that it's a highly polymorphic gene. So what does that mean? That means there's lots of changes. But not only does that gene in particular have lots of changes, but it has the ability to duplicate. And ensuring that a lab is able to not just tell you whether or not you have duplicates of one side or another of that gene, of that is very, very important, because about 25% of all medications require that enzyme for metabolism. So if you're a CYP2D6 metabolized and you're on a medication, you've got lots of copies, you need to know which allele or which phenotype for that specific gene. So star 1 is the star 1, the one that's got multiple copies. Is it the star 4? And these I'm speaking in alleles. And again, I apologize if I'm overextending myself clinically here, but you need to know which one of those it is to know whether or not you're a normal metabolizer or if you're an ultra rapid metabolizer, because that is going to affect your ability to take very specific medications, especially during pregnancy and especially related to behavioral health.
Absolutely. And that's where right now, and this was from the RX Genomics website, about 45 genes. And that was, I showed you on that patient card, and over 250 medications, where I think we're over 300 now. As new medications come out, as long as we know how they're metabolized, which is in part of the clinical evidence that the pharmaceutical companies turns into the FDA for that approval process, we can tell you what type of metabolizer you're going to be. So again, you just need this test done once, and then you'll have it for the rest of your life. And I don't know how I missed a slide earlier, but yeah, what can it be used for? Prescription medications, over the counter, herbal supplements, nutraceuticals, and even some recreational medications. And it's interesting, when I had my test done, I had Blue Cross Blue Shield at the time. They covered it. I was not when I was pregnant, but I mentioned my girls are older now, but I was going to have surgery. I'm like, I want to have this done. I already knew ondansetron didn't work for me from my pregnancies, but again, nice to have it in writing, and makes just feels better knowing like you're going to be believed. You have this lab test that shows that. But we look at a lot of CBD products right now, THL, your marijuana products going on. It will tell you about alcohol. It'll tell you about different vitamins if you are like the MTHFR mutation, if that will metabolize through you. And it's an amazing report, the information that we can get from it to help, again, with patient safety. And we talked about disease states. We have these mental health disease states. It's also very popular in cardiology, pain management, and oncology. Someday it will become a standard of care. Like I mentioned a few times, these antiemetics, they're also antipsychotics or serotonin meds or antihistamines. Pain management doesn't just work on pain, it works on our respiratory system. These cardiology meds, you saw the woman, the hyperemesis patient who ended up, they want to do a cardiovert on her. When you become dehydrated, your electrolytes become depleted. All of a sudden, you're a cardiology patient. Ideally, we prevent this from happening, but if it does, pharmacogenetics is the perfect play for this. I don't know, I slipped that one earlier. Let me go back to how we pay for it, because I think insurances are now, I'm really hoping, are going to become more adept to paying for this. Just like you said, the one that found in for Medicare patients, if it's going to save them that money, we look at it's health economics, right? You mentioned the cost benefit. This is huge, and we just need that maternal health care to step into this space and it become a standard in this area. I have actually a little ahead on time than I thought, so this is good. I wanted to talk about some case studies. How have Carrie and I actually used this in real life here? When you talk about maternal mental health, a lot of women that reach out to me have had a pregnancy, they had severe nausea and vomiting, they've lost their job, their relationships were destroyed, they're physically and mentally spending years to recover from bone loss, from dental decay. Um, Again, mental health is just vast. And they'll reach out to me and say, I really want another child. I always wanted a big family. What can I do to prepare for this? So this is something where we can do the pharmacogenetic report before you get pregnant and help come up with a plan. So if and when these disease states happen during the pregnancy, then we know where to start, opposed to doing this, rolling the dice or throwing darts. Antepartum is very long. To anyone who's been pregnant, 9 months when you have a disease state, it could be a very long 9 months. If your doctor stops your mental health medications because you're pregnant, I've seen it happen all the time. Or you'll see in one of the case studies, I've heard a lot of women tell me their doctor that, oh, we're going to try this, we're going to put you on this because that's what I put all my patients on. And that's what needs to change. That paradigm needs to shift, and the way of thinking said, no, let's find what's best for you. And that needs, Carrie, we mentioned now a few times, if you start an SSRI, it's going to take up to 6 weeks to get to the effect it needs in your body to feel better from it. And what are we doing in those 6 weeks? How do we know if it's working? When should we increase dose? When should we switch to another med or taper down or discontinue? And then, of course, postpartum is just a very, very long time and many changes physically and mentally. And that's where postpartum depression, even I've met moms who have no history of depression, were fine through the pregnancy, and then this happens in their newborn. What are we going to prescribe them now? Or if they were on medications before, now they're postpartum. Do we need to stay on it? Should we change dose? Should we bring it down? And in the US, when a mom has a baby, that next visit's 6 weeks. 6 weeks is a month and a half that this mom is trying to recover from the pregnancy and take care of a newborn, and Carrie, your case and many others, multiple newborns. So let's see what we can do. So what is this on the spectrum, this continuous timeline to give the baby the best chance for the healthy start by keeping mom as mentally stable as possible? So this was a mom I've worked with. This was just incredible what happened to her. So she was taking duloxetine for many years prior to becoming pregnant. Her obstetrician just said, I'm going to stop the duloxetine. We're going to go to sertraline. That's what I put all my pregnant moms on. And I've seen this with teenagers too, not with pregnancy, but just it's the one you had mentioned Celexa earlier. Sertraline is another one where if they've seen it in a clinical study, they've seen it work, then they're going to just stay because that's what they know and that's what they're comfortable with. But she also had hyperemesis gravidarum starting at 6 weeks, and the malnourishment and dehydration, she just quickly fell. So I know what happened. Carrie, you know what happened. I think everyone with us today know what happened. They stopped her duloxetine cold turkey. They put her on sertraline. We have the 6 week window, but now she's also dehydrated and becoming malnourished over the 6 weeks. What's going to happen to those neurotransmitters through her body? And she just called me one day. She said, I don't feel like myself. I'm rocking back and forth. I feel just, I'm living in a fog. I'm severely, I said, there's so many things. Let's look at all your labs. But this came into a big play. And every time, just to keep it brief without going into all the details, she was just shuffled around between emergency room doctors, inpatient doctors, and her OB. And the OB said, we're going to stick with this. The psychiatrist said, well, you were on this, but do what your OB says. Then the ER doctor said, no, we're not comfortable with that. And a pregnant woman, we're going to give you this other medication. This was one of the ones where she ended up on Compazine. Well, first when she went ER and she went to the ER and she'd been there 3 times. They admitted her inpatient. The inpatient hospitalist who was covering when she went in refused to give her a banana bag right away, which I don't understand, because clearly she was deficient in her nutrients. Her labs, her electrolytes were deficient. So slowly they started to replenish those. But then they wanted to go back and start over with the guidelines on an antihistamine because of the clinical studies in that number 1 by ACOG that shows that that doxylamine works. And she's already said, I know it doesn't work. But they made her try that. It didn't work. She ended up being discharged on Compazine and staying on that for a long time. And that's when I realized, looking at her symptoms, that she not only does she not have the right levels of serotonin, but she was depleting her dopamine. And that's where a lot of this is. She got off that, built up her sertraline, built up Phenergan to help with her emesis, got nutrients going again in her. But when that became depleted, went back to the ER, they gave her a shot of Compazine, even though she said, I can't do it. I know how it's affecting me. They didn't believe her. They said, we'll give you a lorazepam first to calm you. And at that point, she was, I think, 4 months in, and it was really just considering termination because she couldn't work. She had a 5-year-old she's trying to take care of. She's very supportive husband, amazing husband, but wasn't getting anywhere with her continuity of care between these different doctors. And this is one of the ones she kept going back to the psychiatrist that she had been seeing prior to becoming pregnant, who said, do what the OB does. And when she was in the ER that last time at 4 months, she said they wanted to admit her to a mental health hospital because they felt she was at harm's risk. She couldn't make clear choices and she was considering termination. But really, all of this was adverse effects from the medication in the subtherapeutic care that she was receiving from all these different doctors. And I just had to share this case because this should never have happened. And it should never have, I just want to make sure it doesn't happen to anybody else. And this is one of these cases where I was trying to help her out as a patient advocate. And when she was inpatient, that was the first or second time, I actually called and I said, I'm her patient advocate. This is what she needs. And they refused to talk to me. They said, you can talk to her OB who will come in tomorrow. And it was the OB that went ahead with the banana bag and tried some other meds, but it wasn't working. And then that was missing. This isn't working. What can we do next? And she was going in and her husband was going in and they were calling me like, what do we do? I'm like, okay, this is what you need to do. But in the end, nobody would listen to her. She did end up having a preterm baby who's about the size of the palm of my hand and is doing well now. But I just want to make sure that this doesn't happen to anyone again. So this is what we knew, though. This is why I could arm her with information and say, so her duloxetine was working fine. I actually reached out to the pharmaceutical manufacturer and they said, yeah, we would love to follow her, see what happened. I really wish her OB hadn't taken her off this. It's one of these things with mental health medications in pregnancy. There's a big retrospective study going on that's been stopped. If you look at all the resources, they're going to say either it's going to show you data from animal studies and it's going to show you that weigh risk versus benefit. There's no clear answer. Is it safe to take? And that's where we have to look at the patient specific. Sertraline did work for her, but again, as Carrie said earlier, it takes up to 6 weeks. We got to build that up. And then you can see with essentially they don't have Compazine here, but same class as your chlorpromazine. So we have stuff going on here. And as I mentioned with other moms, I've seen the Haldol given a lot for emesis. And there was actually a mom who was discharged with an outpatient prescription. I go, oh my gosh, the adverse effects are definitely going to outweigh the benefits. In that case, they're safer, better medications. And when they gave her the lorazepam to calm her in the ER before giving her another dose of compazine, there we are. It's not working if you see it under the benzodiazepines here. So I just need these ER doctors and the inpatient hospitalists to just listen to the patient, listen to the pharmacist, listen to the care team, to work together to have collaborative care so we can do what's best for that patient. And hope that this doesn't happen to anybody else, because now she's on the road to recovery postpartum, and it's a long road mentally and physically to get back to being healthy again. And something I didn't mention earlier, financially, this all ties in with our finances. So let's not waste money on meds that aren't going to work. Carrie, do you want to add anything to that? What are you thinking about this whole situation?
You know what? It's a very sad story to start. But I noticed that one of our, and I'm just going to mention this because it just popped up. She's from Miss Jennifer Ball. She said, I think there's a misunderstanding. There's a 6-week to effect and starting up a SSRI. Switching from an SNRI to an SSRI should not have a 6 time to effect.
True.
True, it should not. But I mean, as we all know, for this patient in particular, when you just stop a medication and you restart a new one that has a different mechanism of action, that can just be challenging as it is. And we know the effects of serotonin on, nausea and vomiting, and that the serotonin receptors are not just located in the brain, they're located in the gut and in the intestinal tract and everywhere else. So bringing that all into consideration. But Jennifer, thank you very much for bringing that up. That is a great point.
And I think in this case too, the norepinephrine is what was becoming depleted. And then by adding the compazine, we're depleting her dopamine. So it's not just the sertraline. Sertraline maybe was fine. I mean, the serotonin. And then she was also taking her ondansetron, which would have been increasing her serotonin, like we said. But we have these other receptors now that are becoming depleted. And in hindsight, looking at it, I think really that's a lot of what happened to her. So yeah, I don't know. We just need collaborative care. I see it in the hospital. Collaborative care work really, really well. At the hospital where I work, when I'm in the pharmacy or in the ER, in the PACU, or wherever I happen to be, and I can talk to the doctors, I can talk to the nurses. We have this amazing team. Carrie, you mentioned we're both Creighton University graduates, and we arranged these rotations during our last year of pharmacy school. And I did one at an ICU in Virginia. And when you see collaborative teamwork, just phenomenal work. We had the nurse, the MD, the pharmacist. We had the case manager there. We had a respiratory therapist because it was ICU, and registered dietitian. And that's another one I tell all the moms I work with. If you're in the hospital, talk to the registered dietitian, because when you go in and say, I haven't eaten in weeks, and you're not believed and they think you're exaggerating, for some reason, the registered dietitians of the hospital, they understand. It was actually in pharmacy school. This is how I got into this space. It was in pharmacy school, and we started learning about ways to feed patients who cannot eat. And I kept saying, why did I have 3 pregnancies and nobody mentioned nutrition at all to me? And anyone that works in mental health knows how important nutrition is. So we can find ways to feed you. Again, risk versus benefit. Every time we introduce a line or a tube of some sort to the body, we're at risk for infection, other complications, but we got to get those nutrients in you and got to get those neurotransmitters working properly. It's not just what medication can you take. This is part of a whole clinical diagnosis, a whole clinical picture. So I don't want that experience to happen to any other mom. Unfortunately, I do see it through the support groups. Every day it's happening still. So this is where I always say pharmacogenetics is this piece of the whole picture. Having a pharmacist on your care team can make all the difference. So this mom, this is one of my antepartum cases. No history of mental health support prior to becoming pregnant. Due to other pregnancy complications, she became very overwhelmed with anxiety and depression. Her doctor started her on sertraline. Again, this is another one because she does with all her pregnant patients. Carrie, you mentioned earlier that a doctor you work with puts everyone on Celexa, citalopram. So we'll see that. I think it's just human nature. We know it works. we've seen it work. Let's stick with it. Why venture out of that box? But again, personalized medicine is the way of the future. And what works well for one may or may not work well for another. And her test showed she was very lucky. Actually, it did. Ondansetron did not because of being an ultra fast metabolizer for cytochrome 452d6 here for different reasons than mine. My ondansetron was the transporter, the ABCB1 gene. So it did take time. The sertraline did work well, but it's a gamble. And I just wanted to put this out there going, you don't know. Let's do the pharmacogenetic test first before we choose our medication, not after, and then see if it works. Any thoughts about pregnant women while they're pregnant and getting started on mental health medications, Carrie?
No, but I do want to point something out, and I'm sure that we've got a wonderful group of ladies here that are reading this. So it says, I know it's got a green check next to the sertraline, but yet you see CYP2C19 intermediate metabolizer.
Yeah.
You may be wondering why that is. Well, sertraline is an interesting medication, and there are others out there that are very similar in the fact that they have multiple pathways they can follow. And so that is part of the reason why you're considered to be a normal metabolizer. You have normal sensitivity to this specific medication. Again, the CYP2C19 gene is just one in a much larger spectrum of what we need to consider here. Along with, when you see those red, yellow, green columns, I don't, when I say this, don't take this the wrong way, but take it with a grain of salt to an effect, because it's not taking into consideration all the other aspects that I had mentioned in earlier. It doesn't look at drug-drug interactions, all right? Mm-hmm. It doesn't look at drug-lifestyle interactions. And to Danielle's point, people are out there, they're taking THC, they're taking CBD, medical marijuana has become definitely all part of our normal and everyday life. And that's okay. But if we know about it and we understand it and we can put all of this into practice, then we can come up with the best possible pathway for the patient with their prescribers.
Yeah, exactly. This is my postpartum case. This mom took sertraline as a teenager, stopped as she got into her adult life through diet and exercise, finding a good balance, meditation and yoga she did as well. Due to changes though throughout her pregnancy and challenges of having a newborn, she was diagnosed with postpartum depression. Her OB prescribed her Lexapro. That's the phrase that comes back to me all the time from these moms, because that's what she prescribes to all her new moms. This mom was terrified to take any medications while she was breastfeeding. And that's one of those things. Then I had her test done. We're waiting on the results. We haven't followed through on that one yet, but she, as far as I know, she's just trying to do mental health support and stay non-medicated route. But here's an opportunity where we might have a medication that will work, that's safe in breastfeeding, but this mom is scared too. So one of the things I like to say, the added benefit of using pharmacogenetics in maternal health care is it gives the mom a sense of understanding how to support her body throughout her pregnancy, and offers that sense of calm to support her growing baby, because so many women understandably do not want to take medications. Let's see what we can do. And that's where pharmacogenomics and pharmacogenetics steps into play. We call it personalized medicine. It goes by many other names as well, to look at your DNA to see how the body, that mom will best respond. So that's what I have put together. We do have some questions to answer. Carrie, actually, let's see. Kelly, did you want to read out loud the first one?
Yeah, Carrie, I know you've got a bird's eye view on it. I don't know if you picked something out that looks good to respond to next.
Sure. So Jennifer, I think we've answered all of your questions, or at least addressed the duloxetine, SSRI and SNRI differences in regards to time to therapeutic effect. Just remember, just taking all this into consideration when we talk about pharmacogenomics, there's tons to consider here. And you're right, there are some patients who will experience nausea and vomiting more so when they are being tapered off of an SNRI versus an SSRI. But precision medicine is all about the individual and addressing those concerns of the individual themselves. There's nothing more personal than your genetic makeup. But I definitely love your insight, and I agree. We all need to do a better job, and me included. one of the interesting parts of, I'm in the process of project management. And one of the little blurbs and paragraphs I read talked about learning how to listen, and how a lot of times when somebody starts to speak, we are already trying to prepare our answer for whatever it is they're saying, instead of stopping, listening actively, and then addressing the whole concept. Something I definitely do all the time, which is just jump right in, like, oh, da 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 da, and you're like, and the person sitting on the other side was, you just didn't hear a word I said, did you? No, I really didn't. Sorry about that. So anyways, I digress. But thank you again very much, Jennifer, for everything that you're bringing to this conversation. We greatly appreciate it. Okay, so Danielle, I'll let you address this one. So this is from Sim, and I apologize if I butcher your last name, Sidhu. She says, hello, I am not a clinician, but curious about precision mental health as far as non-pharmacologic solutions. Danielle, what recommendations do you have as far as non-pharmacologic solutions are concerned?
Yeah, and being a PharmD, I'm probably not the best one to answer, but there are many. First of all, diet and exercise. You know, I mentioned with hyperemesis women, we're taking away their ability to eat, drink, and exercise. I've read studies where exercise as effective as certain pharmacological interventions. So meditation is a big one. And then there's a whole plethora of therapies that you can do without taking medications. And I'm sure Kelly, I don't know, someone on your team would be a better responder to this one, but oh my gosh, there's even like, there's tapping, there's EDMR, there's so many types of mental health therapies, psychological therapies, different types of counselors you can go to. It's a whole picture. There's no one medication, even if you have a great one that works well for you, that's going to give you that sense of calm and happiness to have a perfect life. It's the whole, again, just like I was saying with collaborative care, you want to look at what's causing your stressors, what triggers you have, identify those, and diet comes really into play as well, getting your nutrients. The pregnant women I work with, I find electrolytes have a lot to do with it, but so much comes into play. Our B vitamins and our mental health tie hand in hand. So those are other options. I don't know, Kelly, do you want to jump in? Is that your area?
It's not, I'm not a clinician, or I can't respond to this part, but definitely we have lots of resources on the 2020 Mom website. We also have a lot of different types of providers who are here at the forum, so encourage everybody to network within the Whova app as well. You might get some really interesting and novel information.
Yeah, and medication therapy is not best for everybody. And that's where you want to look at your family situation, your practitioners. Again, we talked about your obstetricians. We talked about your psychiatrists. Who are you seeing postpartum regularly? Are you seeing anyone regularly? There's with telehealth today, oh my gosh, it's so much easier to access counselors than ever before. So take advantage of what's at your resources, what's easiest for you as well, and financially viable. I wanted to respond to a couple things here. Katriana has a lot of really good information. Genetic counselors are available. I was actually talking with a lab, pharmaceutical company that has real interesting type of lab using, what's the word, like digital health. And we're talking about in the works of pairing genetic counselors with pharmacogenetic counselors. It hasn't happened yet, but that's where we want to look at. Again, you can create a whole picture: what's safest for mom, what's safest for baby, and how can we prevent problems or complications from happening throughout the pregnancy. And I love that idea. Like we talked about that one. Let's see.
Yeah, I'd like to jump in here for a quick sec with Dr.
Yeah. Go ahead.
I greatly appreciate it. I've read through this and everything that you typed up. And if you wouldn't mind, two things: could you reach out to us offline, and then we can actually share the resources, that Danielle utilized to put together the slideshow, and then we are more than welcome to, or more than happy to carry on a discussion in those specific regards. And you're right, there are definite limits to evidence. From the very beginning, we have to remember that pharmacogenomics and pharmacogenetics is only about 20 years new. Okay, I remember when I was 18 years old, and I'm dating myself there a little bit. a little off by a couple of years. But I was sitting at my doctor's office waiting to give blood, and there was a wonderful young lady came out in a coat, and she said, "Hi, I'm a resident. I'd like to ask for your permission to utilize your genetic information in a new project." And I said, "Oh," I said, "Yeah, sure." I said, "Is anybody going to find me?" Because I didn't know about genetics at 18. I was like, "Nobody's going to be able to find me. They're not going to be able to track me. They're not going to steal my DNA and stuff." And she's like, "No, no, no. It's going to be, de-identified." I said, "Well, what's the project?" She said, "Oh, it's the Human Genome Project." I was 18, I'm 46. And I knew then when I had somebody coming to ask me about that or had a good idea, I said, at some point in time, we are going to use our DNA to drive our healthcare. And I think we are really on that path. But in maternal health specifically, and yes, there's tons of science that's lacking. There's tons of evidence that's lacking, but we are growing, we are developing, and moving forward from there. And then finally, if you would not mind sharing this study that you posted, I have it pulled up here in front of me. I would love to read the full study on that.
Carrie, I wanted to add the one study is showing that there was no evidence in difference in depression symptoms for women with different PGX status. So one thing I learned a long time ago is there's different labs that work differently. So we have to look at if there's multiple pathways, as you said, you're going to maybe have a primary pathway, many secondary pathways. If that lab is only testing one, or if it's not looking at different variations, or not looking all the, we talked about, it's not just the pharmacogenetic test itself, but the pharmacokinetics and the pharmacodynamics, what diet they're on, what else they're taking, what supplements, this is all going to come into play. So yeah, it's definitely a new science. It's not an exact science. There's room, just like you said, there's room for the future. And, we're happy to be on that train and get us to where it needs to be. There was another question, Carrie, that was put through the app. And yes, did I not? I didn't finish that. There's our emails. Sorry. There's a question put through the app that I found really interesting. I don't have the exact question in front of me right now, but it said, what was the question? Adverse effects in medication in women are double that of men. Can we explain why and what is being done about it? We had a little conversation while we were just waiting to get this started about that question. And I just want to say, I haven't seen that statistic. There are two ways to report adverse effects to medication, one to the pharmaceutical company and one to MedWatch, which is run by our government. But there's so many reasons this could happen. And Carrie, you added some wonderful insights. So I'm going to let you step up and speak about that.
So it's interesting. I think part of the first reason is, number one, most pharmaceutical companies utilize middle-aged men as their kind of target. How are we going to test this? How are we going to make sure it's safe on the market? They don't necessarily include women, minorities, definitely not pregnant women, kids, so on and so forth. Okay. And so we have to take that into consideration. Secondly, men have a tendency to be a bit more what we call hydrophilic. So men have they're less body fat, so there's more water. And women are more lipophilic. So naturally we have more body fat, we're curvier, we were designed that way so that, God said, hey, we're going to make you attractive men. Let's give you a little more body fat. That's just, you don't have to blame me on that part. But anyways, in saying that, when we start talking about medications, Ambien's probably the greatest example that I can think of off the top of my head. It is what we call a lipophilic drug. And they could not figure out for the life of them why it was that the medication itself had such severe side effects with women. So women were sleep eating, they were sleep driving, they were sleepwalking, they were sleep everything. And they'd been on it for a period of time. Well, come to find out that the medication kind of stores itself in those fat cells and then slowly releases. So they were actually getting higher and higher and higher levels of the medication when they took it. So it was never clearing out of their system. And so that's kind of one of my theories as to why sometimes women have more side effects, because we wind up with more of the drug. And then of course you have to bring pharmacogenomics into it. And what does our DNA say? And what are our genes doing? Again, what are you doing in your environment? CYP1A2 is one of the greatest examples with regards to heavy smoking induces CYP1A2. What does that mean? That means you have more of those enzymes to do what you need to metabolize those drugs. So, our environment plays a big part in this. So just kind of keep that in mind when we start talking in context of differences between men and women. Bigger differences are found in the variations in, believe it or not, in ancestry. Okay. And if you look at where you're from, and I got about 1 minute left here, so I'll make this quick, Danielle. If you look at where maybe your ancestry is from, if you are if your ancestors come from, say, the Alaska region, okay, there's a very good chance you may not, and I know this is going outside of pharmacogenomics, but just to give you an idea of how DNA and how your genetic makeup affects different aspects of your life, you may not react the same way to fasting as somebody who's from the equator, or the, simply because their bodies are evolved and their genetics were evolved to the point where they can eat high protein, high fat diets and have to fast and not go to that ketogenic state. And so if your ancestry is from that region, you may not get that same diet effect or dietary effect or weight loss effect you're looking for. And so that's kind of how evolution, genetics, and all of this comes into play, even outside the space of just pharmacogenomics. It's a much larger consideration in all of this. So I'm sorry, I know I went around the world and back again on that one, Danielle. So
no, and it's important. And that's one of the things, looking at genetics. Oh, thank you, Jen. And looking at pharmacogenetics and looking at personalized medicine as a whole, that we can look at where you from, what is your ancestry, and how can we take that to make what's safest and give you the healthiest pregnancy and the best chance for you to have a healthy newborn and a long-term for mom and baby and the whole family. So Carrie, thank you. Kelly, thank you. Did we miss any questions?
No, thank you both. This has been just wonderful. And we had a really engaged, though small group, but I know a lot of folks will catch it on the recording as well. So thank you both so much for being here. And we'll be heading over to our panel 3 on hospital quality over on the main stage in just 5 minutes. So thank you again, Carrie and Danielle. It's been a pleasure.
Ours as well. Thank you. Bye,
thank you very
everyone.
much.